Good evening, everyone.
Good evening.
Welcome to King's College. My name is Greg Morgan. I'm the Vice President for Institutional Advancement here. I'm welcoming you on behalf of Father Looney, our president, who unfortunately is traveling in Atlanta tonight at a conference. He couldn't be here, but we want to make sure that we give you a hearty welcome to King's College. We are so delighted to have you here to hear Aimee's story tonight and have really to be with two of our great King's alum, Dr. Mangan, who's a driving force in bringing us together tonight, and also Mayor Brown. So I will take up no more time than that, but thank you all for coming. We're so excited to have you all, and I really hope you enjoy the evening. Thank you.
Hi, good evening, everybody. Thank you for coming out. I know the weather wasn't that great about an hour ago, and I was thinking, oh my gosh, nobody's going to come. But thank you very much. I want to thank a lot of people, but I'm going to wait and we'll do it later. But the people you see here tonight on the panel are here on their own time, giving up their time to give you information about colorectal cancer. And I really want to say thank you to the physicians that are here tonight, because you're going to save a life tonight, hopefully. Okay. My daughter Aimee is here, and as you may or may not know, we titled this Aimee's Story, because about a year and a half ago, Aimee was diagnosed with a severe case of colorectal cancer. And Aimee's going to we're going to show a video that we taped of Aimee's story. And it goes from the beginning right to where she's at today. So that's going to be something that we really wanted to share with you. But Aimee's here to also answer questions. If anyone has questions about what she went through, and please ask questions. We have a lot of very skilled physicians here tonight that will go into some details for you, answer any questions that you may have sent in already or that you will be presenting. So please ask the questions. We're going to start the video with the session time with the video, but I just want to say this has been about a year-long process putting this together. It initially started when Aimee was diagnosed with colorectal cancer, and a friend of ours did a fundraiser at Chris Nix. And because of the fundraiser, a friend of mine that I grew up with, and Tom, we won't talk about some of the things we did when we were younger, but Tom was a gastroenterologist at the Mayo Clinic, and Tom called me and said, George, I'm concerned about colorectal cancer in the area where we're living. And he said, I want to do a program with you. He said, please reach out to the colleges, reach out to the medical school, reach out to the hospitals in the area, and see if they'll partner with us in providing some information about colorectal cancer, the signs, the processes that you people go through. So I reached out to, I physically went to every single college, university, hospital, and school of medicine and asked everyone would they take part, and they all said yes, we're happy to do that. And that's what you have tonight. It's a concerted effort. We've also had in-kind people that helped us out with the Times Leader, the Citizens Voice, also PA Live, and WIOK Radio. They all tried to broadcast this and put the word out about tonight. So I'm not going to take too much more time, because it's important that you see the video and talk to the physicians rather than talk to me, because I'm just the father of someone who beat cancer, but you want to talk to the person that actually beat cancer and the physicians that are going to help hopefully someone else beat cancer. So I'm going to introduce the video, if you don't mind.
When the summer of 2022 started, I began to have pain when swallowing. Being that I've suffered with IBS and acid reflux for the last 25 years, my doctor felt the next step should be to schedule a barium swallow test and a referral to see a gastroenterologist. With that referral, he said I should get new blood work done while waiting for the next available appointment. I was not prepared for what was to come. I went for blood work on a Friday morning. Around 5 p.m. that night, my doctor called, which was very surprising. He would call on a Friday night with my blood work results. He asked me if I was able to stand up and said my results were very alarming. Turns out my hemoglobin was a 5.4. For reference, an 11 is classified as anemic. I told him I was planning to watch my nephew that night. He said, no, you need to go to the ER and get a blood transfusion. I said, I think I'm okay and I don't need to go to the ER. He then said, I'm not asking you to go, I'm telling you, it's very dangerous and you need blood immediately. The ER doctor said she thought I may have an ulcer, and with my chronic stomach issues, she would like me to have an endoscopy and colonoscopy at the same time. My colonoscopy revealed a rectal tumor the size of a walnut. I was completely shocked that I must have missed symptoms. With my new diagnosis, I was referred to a colorectal surgeon where I was given the recommendation to do surgery to remove my rectum, anus, and have a permanent colostomy. I wasn't mentally ready to handle such an elaborate surgery, so I went for a second opinion. There they gave me the option to do aggressive chemo and radiation with a 50-50 chance of preventing the surgery and colostomy that I was so intimidated by. In November 2022, I did 30 rounds of radiation with oral chemo, and in March 2023, I started 5 rounds of IV chemo along with 5 months of oral chemo. I would go in for scopes to check on the progress that the treatments were making. Unfortunately, in July, I was told the treatments did not work and I would need to have surgery. On September 12th, I underwent a 10.5-hour surgery. They removed my rectum, anus, and 80% of my colon, as well as creating a permanent colostomy and reconstruction. Thankfully, the surgery went well and successfully removed all of the cancer. I was in the hospital for 6 days. I was then transferred to Allied Services Skilled Nursing and Rehabilitation Center in Wilkes-Barre to recover and start therapy, to become more mobile and take care of myself. If it wasn't for the swelling problem, which doctors were never able to find a reason for, that forced me to call the doctor, and the recommended blood work, I would not be here to talk to you today. One thing I have learned is to not ignore the little signs and symptoms. Don't put off getting your regularly scheduled testing, such as routine blood work and colonoscopy. You can prevent so much if you're fortunate to catch it early. If I can help one person says to me, can I talk to you about what you went through so that I don't have to be afraid, I would talk to that person. Because I would like that person to come to me and say, hey, I've had this for 5 years, I've had it for a year. And this is what the first few months are gonna look like for you. And you get used to that, and then it's your new normal. Like I say it all the time, it's my new normal, but I'm here to talk about it, so that's what's important. And I had to show my girl all along I was being strong for them because I wanted to show them that it's not the end, it's the bump of the road. And things are gonna happen in life. Nobody's life is perfect. If this happened to me so I can help someone else down the road, then that's why it happened to me. I encourage everyone to know the symptoms, know your family history, get screened, and follow your doctor's orders.
Thank you, Aimee, for sharing your story tonight. I'm sure you'll have many hugs and congratulations and perhaps some questions as the evening goes on. Thank you all for being here tonight. Mayor Brown told you the story as to what led to this evening. I'm going to make my remarks very brief, but I'm going to tell a little anecdote. If anybody knew my father, he could tell a story, so I got a story to tell. But as far as colorectal cancer nationally, there's 150,000 new cases of colorectal cancer in the U.S. annually. Every year, 150,000 people. 13% of them are under the age of 50. And we're finding in northeastern Pennsylvania that the cancer rates are lowering. And this has been reported in the New York Times and CNN. It's a nationwide thing, but we in northeastern Pennsylvania are a small community who can talk among themselves as we are tonight and do something that I don't think the New York Times can do in such an intimate way. You'll hear from our colleagues that 9 to 10% increase since 2020, that's in the last 4 years, and that there's 50,000 deaths a year. The reason we're here tonight is talk about screening and risks and symptoms, and we'll go over that in a very clear and concise way. But if you're age 45 or older, 40% of people that should be screened haven't been screened. So those people are all at risk for colon cancer. And in the age 45 to 49, which we're lowering the bar to, at this point in time, only 20% that are at risk. 1 out of 5 have been screened. So we have to do something about that. Now for the story. So I just came into Wilkes-Barre yesterday morning. First stop was at a dry cleaner to get my coat and tie cleaned up for tonight. I'm speaking to the young man at the desk, and he said, "You want this overnight?" I said, "Yes." He said, "Why?" I said, "I'm giving a lecture tomorrow night." "What are you talking about?" I said, "Colorectal cancer." He said, "Oh, that's funny. My mom had ovarian cancer, and I have Lynch syndrome." Now, Lynch syndrome is a hereditary non-polyposis colon cancer syndrome. This kid, who's 24, knows that he's got the gene. Well, he knows that his mother has the gene for colon cancer, ovarian cancer, and he says to me, "I haven't been tested yet. My mom wants to wait." And my sister, I don't know if she's here, said she doesn't want to be tested because she doesn't want to know. Well, I said to him, if she doesn't have the gene and she's 30 years old, she doesn't have to spend the next 50 years waiting to find out when she's going to get it. She'll know she's not at higher risk. So I leave there. I'm currently doing something for my cousin and had to meet a lawyer. The lawyer says, "What are you going to do after the day?" And I told him tonight. He said, "Oh, that's funny. My mom had colon cancer and I've had polyps. And I go every 3 years, and take these big polyps, and oh yeah, colonoscopy, no big deal." That's stop number 2. Stop number 3 was at Abe's Hot Dogs, and and we didn't talk about colon cancer there. Stop number 4, I have to go to the bank for my cousin again. I'm talking to the woman, and it was an arduous process where, I have death certificates, I have power of attorney, all that stuff. And so she says, "Well, what are you going to do?" And I start telling her about this. She said, "Oh my God, that's crazy." She said, "My mom had renal cancer and my dad had colon cancer, and it was a renal pelvis. So she has Lynch syndrome." And then finally last night when I went to dinner, I met Amy's daughter. So in the course of 12 hours in Wilkes-Barre, 80% of the people I encountered, 80% of the people I encountered, out of the blue, I mean, the guy at the dry cleaning, the guy at the bank, the guy in the lawyer's office, Amy's family. I mean, this is incredible. But the problem is, I have no shame in talking about anything, but the problem is people don't like to talk about this because it's private, it's intimate, and people don't want to share this. But I want you to make sure that you share it with your doctors who know, and you'll hear in a minute, the signs and symptoms of what you should be looking for and what can be prevented. Because although colon cancer is the number 2 cancer killer in America, it's highly preventable. And the reason it's killing people is that they don't do anything about it. So with those introductory remarks, I'm going to turn it over now to my colleague, Dr. Aimee from Commonwealth Health.
Well, thank you all for coming. So as we heard today, we're here today to raise awareness about colon cancer, and there is something we can do about it. Most of the patients that they come to me in primary care setting, they either don't want to know if they have cancer or not. They say, well, it's meant to be, then I'm just going to take it. And the other, they don't know that we can do something about it if it is early. So this is why we're talking about this here. This is the colorectal cancer is a very common problem, as we heard here all the stories. 80% of the people he met yesterday had it here in the community, representing the 3rd most common diagnosed cancer worldwide. And relatively slow development of that cancer give us the chance that we can screen for it and do something about it with different modalities of screening that we're going to hear from my colleagues here about in a minute. We can do stool analysis, endoscopies, we can do even imaging. The incidence, usually it goes up with age, except if there's family history, if there are risk factors. So the other thing, if you're young even, and you have those risk factors, suggestive signs and symptoms that we're going to talk about, please talk to your doctor about. So rectal bleeding is not always hemorrhoid. So if you have rectal bleeding, you should talk to your primary care about it, especially if the blood is mixed with stool. persistent or chronic abdominal pain, bloating. Also, we heard from Aimee, iron deficiency anemia that's unexplained. If you have that anemia, we have to look, we have to do the scopes, upper scope and also colonoscopy. So please be aware of the prevalence of that colon cancer, and I want you to know today that we have something to do about. And now I'm just going to turn it to my colleagues to talk more about that.
Tetris here. All right, thank you. We're going to talk a lot about colorectal cancer screening tonight. And as a gastroenterologist or a physician who performs endoscopic procedures and colonoscopies to help decrease, to help prevent colorectal cancer, I can say that that's one of the most rewarding parts of my job. Doing a procedure, removing a polyp, and being able to tell a patient that, I just removed something from your colon that, now will no longer be risk of turning into cancer in the future. Colorectal cancer screening is unique in that our goal with colorectal cancer screening is not only early detection, which is the goal of most cancer screening programs like mammography and prostate testing, CAT scans for lung cancer. Our goal with colorectal cancer screening is actually prevention. Because we can find and detect polyps, which are precancerous growths, before they are symptomatic or causing any problems, and remove them and prevent them from developing into cancer. Screening only works, though, when patients have it done. And we've already heard stories about patients not wanting to have screening done. There's a wealth of data from the CDC, Center for Disease Control, and several databases that look at screening rates or compliance with screening recommendations. This data is from 2022. It's from a survey called the BRFSS, or Behavioral Risk Factor Surveillance System. You can see where Pennsylvania falls on this chart is kind of in the middle as far as screening compliance. Colorectal cancer screening rates, this is for patients age 45 to 75, which you're going to hear is the age that we typically recommend routine colorectal cancer screening for. Patients in that age group that have had at least one colorectal cancer screening test. Now that doesn't mean that they're up to date. They could have had a colonoscopy at age 50 and still be 70 years old. But patients that have had at least one colorectal cancer screening test nationwide, the median across the U.S. is 66.9%, and that's exactly what the average compliance rate is across the state of Pennsylvania. So 66.9% of Pennsylvanians aged 45 to 75 have had at least one time in their life had a colorectal cancer screening test. Locally, the data is a little bit more worrisome or concerning. This data, again, from that BRFS survey and also this NHIS, National Health Interview Survey. This data is a little bit older, from 2017 to 2019. But this is, again, showing patients who have had a colonoscopy within the past 10 years. So these patients are compliant with current screening recommendations. The Luzerne in Lackawanna County, I don't know if there's a pointer here. No. Luzerne County is the yellow county up in the upper right corner, and Lackawanna County is the dark blue county to the right and above that. Luzerne County is, this data from 2017-2019 is 62.9%. So only 62% of patients have had a colonoscopy in the last 10 years or are up to date with a colon cancer screening. That ranks 40th out of 67 counties in the state of Pennsylvania. Lackawanna County is a bit better. Their compliance rate is 70%, which ranks 6th in the state, and across the state, the range, the variation is from 52.4% to 75%. So certainly locally in Luzerne County, as you can see, we're on the lower end there, and certainly much better job that we could do. This is a similar chart showing the same database, same survey, looking at patients who have had a colon cancer screening test. So the previous slide was looking at colon cancer or colonoscopy only. This is looking at a screening test. So Dr. Penny Metz is going to talk about other, different screening modalities, but this is showing patients who are compliant with having a screening test. And you see here, Luzerne County is red. We're in the lowest percentage at 63.2, which ranks 60th out of 67 counties in the state of Pennsylvania. Luzerne County or Lackawanna County, again, 72%, which ranks 12th in the state. I think an important thing when we're talking about colon cancer screening and colon cancer screening guidelines is it's very important to know your risk factors, and risk factors vary from individual to individual. I think Aimee even mentioned in her video there, know your risk. I would implore everybody to, I think it's taboo. We don't talk about our medical history, our family history, but I would ask all of you, next time you're together with your family, talk about your family history. Find out what, your uncle or cousin or grandfather and other relatives died from. We hear this all the time. Patients say, "Oh, my family member had some kind of cancer." But it spread to places, but they don't know where it started. It's very important to know that history and be able to individualize your personal risk so that we can make the appropriate recommendations. To elaborate more on risk factors, go through these. Age certainly is a very important risk factor. As we get older, our risk of colon cancer increases. Historically, we've considered colorectal cancer as a disease that affects older people, highest prevalence in the 60s and 70s. But recently, we're seeing a significant increase in incidence of colorectal cancer in younger individuals. What's called early onset colorectal cancer occurring in individuals under the age of 50. In fact, people born in the 1990s currently are at a higher risk of developing colorectal cancer than people born in the 1950s. So we don't know necessarily why that is, what's contributing to that entirely, but that's a very worrisome statistic. People that are in their 30s now are at higher risk of getting at significant twofold increase, 2 to 4-fold increase of developing colorectal cancer than essentially their parents, their parents' generation. So that's concerning. Family history, as I said, very important to know your family history. If you have a first-degree relative who had colorectal cancer or had an advanced precancerous polyp that was removed, you could be at significant increased risk of colorectal cancer, and it may change the age at which you need to start getting colorectal cancer screening. If you have a first-degree relative who had colorectal cancer under the age of 60, you need to start colorectal cancer screening earlier, either at the age of 40 or at least 10 years before the family member was diagnosed with colorectal cancer. So if you had a parent who was diagnosed with colorectal cancer in their 40s, you may need to start cancer screening in your 30s. Genetic cancer syndromes, Dr. Mangan talked about this in the introduction. He mentioned Lynch syndrome. Lynch syndrome is one of the more common genetic syndromes that we see that is associated with a significant increased risk of colorectal cancer. The majority of cancers, colorectal cancers that we see are what are called sporadic, meaning they occur by chance or bad luck. But there are about 5% of colorectal cancers are associated with genetic syndromes. The two most common are called FAP, or familial adenomatous polyposis. Those patients can have thousands of polyps and invariably will develop colorectal cancer because they have thousands of polyps. Lynch syndrome, as Dr. Mangan mentioned, we refer to as hereditary non-polyposis colorectal cancer, meaning they don't necessarily have to have a lot of polyps, but they tend to have colorectal cancer at a younger age. It can also be associated with non-colon cancers. Again, to elaborate on what Dr. Mangan mentioned, uterine, ovarian cancer, renal pelvic cancer, ureteral cancer, small bowel cancer, some brain cancers, as well as possibly prostate cancer as well. Patients with inflammatory bowel disease, typically these patients are going to be followed by a gastroenterologist for management of their disease, and we will be able to make appropriate recommendations for when they need to get colorectal cancer screening. But patients with inflammatory bowel disease, particularly in patients who have had long-standing ulcerative colitis or Crohn's disease that affects a significant portion of the colon, do have a significant increased risk of colon cancer and need to have more frequent colorectal cancer screening, particularly once they've had disease for more than 8 to 10 years. Abdominal pelvic radiation, this particularly applies to patients who have had childhood cancers where they've had radiation. We do see an increased risk of colorectal cancer in those patients, and there is some recommendation that they should have earlier and more frequent screening. There are some risk factors that aren't necessarily associated with the need to have they don't necessarily change the screening guidelines. For example, certain races, particularly in the U.S. even, African Americans do have an increased risk of getting cancer. Men, particularly, there's not necessarily a discrepancy between incidents, but they tend to have different outcomes and higher mortality when they do get diagnosed with colorectal cancer, but they don't necessarily impact the screening guidelines or recommendations. Medical comorbidities, meaning other health problems that can be associated with an increased risk of colon cancer, like obesity, diabetes, are some of the common things, and then diet and lifestyle. Particularly, I'll mention here sedentary lifestyle, smoking, alcohol use, and something that's interesting, red meat. The World Health Organization, in a recent report, considered processed meats, like sausage, bacon, things like that are processed, and red meat as potential carcinogens because of the association with the increased risk of colorectal cancer. That's all.
Thank you, everyone. Thanks for being here today, and thanks for the panel and everyone having me down here today. My name's Penny Mehta. I'm one of the GI doctors here at Wilkes-Barre General Hospital. My goal in the next couple of minutes is to kind of introduce some of the screening tools. I know my colleagues did a really good job kind of expressing about things to look for, things that should really make you knock on a doctor's door and get some kind of screening. But really the big question often comes, what is the right test? And I'm sure everyone here will agree that some kind of screening is better than no screening at all, right? So just to kind of give you what the options are, if you look on the screen on the right upper side, that's the basic stool tests. So these are tests called FIT test or FOBT, and these tests typically are looking for blood in the stool, They're done usually annually. If you see a PCP or any other doctor in general, they'll probably give it to you. You can go home, get it done, drop off the test in the lab. And if it tests positive, you're going to need a colonoscopy. Now, if you move down a little bit, that's the CT colonography, all right? So a CT colonography is also another way to screen for polyps in the colon and also cancers too. They recommend per guidelines every 5 years. There's a few limitations with this test. One is you can't really pick up certain lesions that are really subtle, small. If they're less than 5 millimeters in size, they can go, missed on the imaging. But it is a 95%, 96% detection rate, so it's actually pretty good. But the caveat here is you still have to drink a little bit of a prep the day before, and rather than coming to see an endoscopist or a colonoscopist, you would actually go to a radiologist, and you would get on a scanner, a CAT scan, gives you a three-dimensional view, and then they let us know if there's any polyps in there. If there is a polyp, then you're circling back again for a colonoscopy, right? So moving across now at the bottom, the flexible sigmoidoscopy, and that's an obsolete test. It's been around for a long time. It's still included in the guidelines, but you don't see much of this being talked about because back in the day they used to use these in the clinics just to at least assess the left colon. And once again, this test has some limitations because you're only getting an assessment of the left colon. What we know is that as time goes on and as people age, the risk of colon cancers or flat polyps or certain types of polyps is actually much more predominant on the right side. So if you're only doing half of the scope, you're not really picking up anything on the right side, right? So this is per guidelines every 5 years, and like I said, only assesses the left side of the colon. Now moving on to the lower left, and that's the test that everyone hears about. You might have seen it at a Super Bowl commercial. They're putting posters everywhere, and this is good in a lot of ways. It is a good test. It actually has a 91, 92% detection rate. What it's essentially doing, unlike the tests that we talked about up there, is that it's a little bit more advanced. Every day, your colon is shedding a bunch of cells. Quite the contrary of what a lot of people think. Your stool is just nothing but a lot of shedding of cells, colon cells. So if you happen to have an abnormal polyp tissue or a lesion in the colon, that's also going to shed. And this test is actually detecting the DNA. So it's far more advanced than the routine test that we used to use back in the day. This is a good test in the sense that it has 91%, 92% detection rate. Of course, there's some false positives that do happen. So I often get patients who get this test, they come panicked, and they want to sit in my room, and they want to get a colonoscopy right there and then. Okay, but I understand that dilemma, but the issue with that is it does create a little bit of, anxiety and all that kind of stuff. But quite a lot of times when we do these scopes on patients with positive Cologuard, most of them end up being negative. But once in a while I'll admit, I do run into polyps, some very high risk, and sometimes even malignancies. So you can't completely negate this test as being not valuable. It is a good test. It's usually done in the privacy of your home. You can get this at home as a delivery, apply the stool sample, mail it out. There's a place that actually processes the test and then reports the test. But once again, this would need a colonoscopy. All right, so when I say the word colonoscopy, I see 2 steps back on every patient, right? So the first step is usually, well, what's the prep? What is this prep that you're talking about, right? And then the second step is anesthesia, right? So those are the 2 big things that everyone shies away from. So if I were to pick you as a patient, and let's say you were coming in for a colonoscopy because one of these tests lit up, all right? I would have a conversation with you in the clinic, and then someone from our office is going to pick a time and date for you. And you're going to have to take that specific day off because you're going to need someone to drop you off and pick you up, right? The day before, you're going to be given a prep. That's a clear diet where you're not allowed to eat any solid foods all day long. Somewhere around 4 o'clock or 5, you're going to get a colon bowel prep. And there's different commercially available options for it. You can get generic versions, you can get fancy and try to do pills. So there's keeping patients' tastes in mind. There's a lot of different options nowadays. So I certainly think no one should deter just thinking that the prep is going to be bad. I'm not going to lie to you, it is painful taking it, but at the same time, we've gotten better at making this more accessible to patients. Okay? So you do the prep, you clean yourself out, and then you show up the next day, either in the hospital setting where the scopes can usually get done, or some people have private practices where they have their endoscopy centers. And you show up and you have an anesthesiologist waiting for you there who assesses you, pre-ops you, makes sure you're good to go, and picks the right type of cocktail of medications to get you comfortable, right? Then you move on with the IV line, you come into the room, you have 3 people around you, you have me with the scope, a long flexible scope, about, I would say most people's colons are about roughly 5 feet long, right? So you have a long flexible scope with a tip of the scope that has a camera. And then you have a CRNA right in front of you that's monitoring your heart rate, lungs, and everything else. You have a tech that's helping me out with all the biopsy forceps and all those kind of things, tiny instruments that we need sometimes in the scope. And then you have another nurse in the room documenting, everything that's going on. So you really only have 3-4 people in the room, doors are shut, you have your privacy, you get your procedure, which usually lasts about 25-30 minutes. And then they roll you out. In the recovery, you probably spend another 15-20 minutes. Most places usually about that time. And then you pack up and you leave. Just no driving on that day, no heavy, lifting or jumping off or anything like that. Okay. But the next day, you're basically back to yourself. You're back to work, whatever you need to do. So that, in a nutshell, is what a colonoscopy is. Now, if you ask the question of why we're doing a colonoscopy, so colonoscopy, unlike the rest of the tests, is both a diagnostic as well as therapeutic. So it's really both. So you're getting the best bang for your buck. But again, I have to stress, if you have reservations about a colonoscopy, you should ask your primary care doctor. And now that you guys know a little bit about what the available options are, you can certainly consider those as the first step. Some kind of screening, again, is better than no screening. So a quick snapshot of what we're looking for when we do a colonoscopy, right? Most of the polyps are benign. Actually, in fact, most of the polyps that we take out, they're benign polyps or they're precancerous polyps, which means that they carry something in them which we do not know if they can turn into cancer down the road, right? That's why we take these polyps out, and they all get classified as benign polyps. The problem is, when you have a polyp that mutates or there's something that happens at a cell level, now you have some abnormal tissue that's growing in that polyp, like that second last on the right. Once you start developing that and no one really does a screening on you, you don't get picked up, you don't get a colonoscopy, soon enough that abnormal tissue starts invading into the colon wall. And sometimes you might be fortunate to even get that colonoscopy at that junction, and I might be able to take it out. I might see a polyp and it hasn't quite indurated into the colon wall, and we resect the polyp, and that's considered curative, which means that you didn't need any surgery. You actually just got a colonoscopy and we took the polyp out for you, right? But if it invades into the colon wall, that's the problem. That's where we have not given an opportunity to screen this at a heads up before. And now we're dealing with more of an invasive cancer, which I'm sure my colleagues will help you with the understanding as far as treatment options, radiation, chemo, and all those kind of things. So in a nutshell, I think what I placed on the right side is just kind of the national guidelines. If patients come in, I tell them one single take-home point, which is get some kind of screening. But if you're not getting any kind of specific colonoscopy, at least talk to your doctors about what the available options are. Okay? So that's pretty much it.
Hi, I'm Tom Erchinger. I'm a colorectal surgeon with Geisinger at Geisinger, Wyoming Valley. I apologize, I'm getting over a cold, so my tone is about an octave lower than usually it is. But nevertheless, I think we can get through this. Before we get into the surgical part of it, I do want to stress, you've heard a lot about screening and all. The key to beating colon cancer is prevention. And that has to do with screening, removing polyps before they become cancers, identifying the risk factors, everything that's been discussed already. That's how we're going to beat it. Unfortunately, many people who are found with colon cancer do require surgery. Historically, surgery was the only curative treatment for colon and rectal cancer. But as you heard some, you will hear some more later, there are other options now. Some early cancers can be removed endoscopically without requiring a radical surgery. And then for rectal cancer, again, we'll hear more. Sometimes rectal cancer can be treated. Usually it requires additional treatment besides surgery. Sometimes that additional treatment can be curative, up to 30 to 50% of patients these days. A lot of that depends on tumor biology and genetics and the responsiveness of the tumor to these other treatments. I'm here to talk a little bit about surgery though. The big fear of patients with surgery is I'm going to end up with a bag, a colostomy bag, a poop bag. And while that sometimes is necessary, it by far and away, the most likely result is that you can resect the tumor and restore continuity, hook things back together to where bowel function is normal. Most patients do not require colostomy. Sometimes a temporary colostomy or ileostomy is required, and then those can be reversed. Besides just the fact that surgery doesn't necessarily require a colostomy, many advances have been made in recent years. Most surgery can be done minimally invasive. It used to be that surgery for colon and rectal cancer required a large incision through the center of the abdomen, many days in the hospital, and a prolonged recovery. These days, most colon and rectal cancers can be treated minimally invasive, meaning either laparoscopic or robotic. We generally use about 5 small incisions. One of those incisions has to be made a little bit larger in order to remove the affected part of the colon. But even with that, we generally shoot for a hospital stay of 3 days. Most patients can, sometimes patients go home the day after. Sometimes it's a little bit longer. Some institutions are even doing same-day surgery for the optimal patient, where you can do the surgery, observe them for a short time, and then they can go home the same day. I wouldn't say that's standard of care right now, nor is that frequently done, but it is a possibility, and it shows us where we are going in the treatment of colon and rectal cancer and many surgeries these days. One thing I do want to stress importantly though, besides prevention, is that treatment of colon and rectal cancer requires a multidisciplinary team, a team of experts. It's not just a matter of doing surgery or just doing chemo or getting a diagnosis and going straight to a treatment. Virtually all of our patients with colorectal cancer come to a multidisciplinary team clinic session where the tumor is discussed by experts from our radiologists, our pathologists, our surgeons, our medical oncologists, our radiation oncologists, gastroenterologists, all come together to discuss each individual tumor. And that leads to personalizing the treatment and determining what the best treatment is for that. Most colon cancers, and colon cancers are different from rectal cancers. They can almost be considered 2 different organs. But most colon cancers do end up requiring a surgery, and that's the primary treatment for it. Once we know the staging and all, then additional treatment could be required with medical oncology, with chemotherapy. Radiation is unusual for colon cancer. On the other hand, rectal cancer is almost, I wouldn't say all the time, but much more frequently treated prior to surgery with combined chemotherapy, radiation therapy to shrink, make the tumor more resectable, and sometimes to cure that tumor. So the most important things I would like to leave from surgery is that surgery is not the way we're going to beat this. We can beat some, but prevention, screening, removal of polyps before they become cancers is the goal. When surgery is required, frequently additional treatments are required in addition to that, and that requires a multidisciplinary team approach where we get all the specialists together. I don't want to go into specifics of different areas of surgery. I'm happy to answer questions when we get to the discussion part, and I think I'll leave it at that, and we'll go on to our next speaker.
Good evening, everyone. My name is Ahmad Hanif. I'm a medical oncologist at Geisinger, Wyoming Valley. And I'm going to talk a little bit about the colon cancer from a medical oncology standpoint. So first of all, we're going to talk about how big of a problem are we dealing with, and what is the comparison between where we're living and the rest of the country. So a lifetime risk of developing colon cancer for an average person in USA is 1 in 24. It's 1 in 23 for men and 1 in 25 for women. If you think about it, that's quite a high number. And we easily congregate in groups more than 25. And to think about it, that one person on average among that group can develop colon cancer, that's a little scary to think about. When we look at Pennsylvania, the risk is almost similar. It's 1 in 22, so not statistically different. When we talk about incidence per 100,000 of population, overall in the USA, the risk is 36.6. In Pennsylvania, it's a little bit higher, 40.7. But in Luzerne County, it's much higher, 47. Now, overall, in the whole country and in Pennsylvania, the incidence and mortality rates for colon cancer have decreased since the year 2000, except this one group of age 20 to 45, where the incidence has increased from 6.6 to 10.1. What causes that? We're going to get to that in a minute. We don't know exactly, but we have some thoughts. And the same pattern with incidence, the rate of death from colorectal cancer for Pennsylvanians have also decreased between 2000 and 2016, with an average annual percentage change of negative 2.9%. That means each year from the year 2000 onwards, the rate of death from colon cancer has decreased by about 3%. That is similar to the whole country, and that is attributable to a lot of different factors. Yes, there are some new chemotherapy drugs, there are some new other systemic drugs, but also advancements in surgery, better infection prophylaxis, and generally better care has contributed to all of this decrease in colorectal cancer. Talking about survival, it greatly depends on the stage of diagnosis. And my colleagues in gastroenterology, they stressed upon the prevention part of the colorectal cancer, but also colonoscopy and also getting timely medical care can help us diagnose colorectal cancer at an early stage, which we call localized stage, meaning the cancer is still where it started. And the 5-year survival for that kind of stage is 91%. And in Pennsylvania, it's almost the same, 89.5%. When it starts spreading to the lymph nodes around that area, we call it regional spread. Still curable, but now the 5-year survival drops to around 72%. Same in USA and in Pennsylvania. And when it goes outside of the area, which we call distant disease, it could be the liver, the lungs, could be the wall of the belly. Now the survival rate really drops down, almost 13% in the whole country and around 15.4% in Pennsylvania. Taking everything together, this 5-year survival from all comers with new diagnosis of colorectal cancer, the survival is about 63% in the country. And looks like Pennsylvania and northeastern Pennsylvania are doing about the same, 63.2% and 61.9%. So we're doing okay with the treatment. We are at par with the rest of the country. We can do better with prevention because we have increased incidence than the rest of the country. Now, a few words regarding colorectal cancer in the young adults. In the colorectal scheme of things, we consider anybody less than 45 years of age as a young adult. the incidence is rising, as we discussed. And the mortality rate, meaning the risk of dying from colorectal cancer, overall it's decreasing. For this age group, it's not decreasing. So this tells us that this is probably a little different form of cancer than what we see in the older folks. Could be related to biology, or could be related to the younger people often ignoring their symptoms till it's too late. When we talked a little bit about the left-sided and the right-sided colon cancers, and in younger people, most of the colon cancers are in the left side and in the rectum. So now what causes that? What's causing the increased incidence? We don't know for sure. We know that the risk factors for colon cancer, the sedentary lifestyle, obesity, smoking, consumption of more processed meats, and decreased fiber in the diet, these risk factors are increasing in our younger population. So that could explain at least some part of it. But there's also some suggestion that these cancers have a different biology, and maybe there is some immune mechanism at the very heart of it. And this is still an area for active research, and I think more things to come in the next few years. And I'm just going to talk briefly about the things that I do in the clinic, which is chemotherapy or other things that treat the cancer everywhere in the body. Chemotherapy is any drug that kills the cancer cells directly. It's usually toxic to any cells in the body that are trying to divide rapidly. Most of the time that's the cancer cells, but that's where the side effects of the chemotherapy also come on, because such as our hair follicles, they're always dividing, so many people lose their hair on chemotherapy, and so on and so forth. We use chemotherapy for two different purposes. It could be before or after before or after surgery to increase the chances of cure from surgery. Or if surgery is not an option, then we can use chemotherapy to prolong life and reduce the symptom burden. There are many different options for chemotherapy that are available. There's some oral options available as well. And most, if not all of the time, these chemotherapies are given as outpatient, meaning the patients come to our clinic and then go back home after getting the chemotherapy. One major issue was giving this specific chemotherapy called 5-FU, which is given continuously for 2 days. And 15 years ago, we were admitting everybody to the hospital to give that chemotherapy. It's a really well-tolerated chemotherapy, but this is the best way that it could be given. But nowadays, we have these pumps that you can just take home, and the pump keep on giving the chemotherapy at a very slow pace. 2 days later, the patient comes to the clinic, we get them off, and that's it. So the goal is to keep the patients at home and not let them get admitted to the hospital unless absolutely needed. The newer form of treatments, one is the targeted treatment, which is different than chemotherapy because this attacks specific proteins on the surface of the cancer cells. So they are much better tolerated than chemotherapy. However, for colon cancer, at least at this time, most of the time we combine them with chemotherapy. They do not work that well on their own. The other new talk of the town is immunotherapy. So far, the role in colon cancer is limited, and we usually reserve the use of immunotherapy for colon cancers that are hereditary or that have certain mutations in them. And then one other form of treatment that is on rise for all the cancers, including colon cancers, is called biomarker-directed therapy. And that means that we have some medicines that work against specific kind of mutations. But if somebody does not have that mutation inside the cancer, then those treatments are not going to work. So we frequently order these tests called NGS, or next generation sequencing, which tell us about hundreds of mutations that can or cannot happen inside the colon cancer. And if someone has one of those mutations, we can target these biomarker-directed therapies. And just a hint of hope here that in 2023, the FDA approved 3 new drugs or combination of drugs for the treatment of colorectal cancers. So good things are on the horizon. That's it for me. I'm going to pass it over to Dr. Jiang, who's a radiation oncologist at Erchinger.
Hi, I'm Dr. Julie Jiang. I'm one of the radiation oncologists at Geisinger. And hopefully you never need to see me. Everyone here has now gotten their colorectal screening and all the polyps are taken care of. But if you're unlucky and the tumor is a little bit more advanced, doesn't mean all hope is lost. As Dr. Hanif had talked about and Aimee went through, we can do chemotherapy with radiation. And as she mentioned, there's about a 30 to 50% chance that you might not even have to do surgery and worry about a bag or things like that. So the main points that I want to kind of mention is that not everyone needs radiation treatment. Very early stage colorectal cancers do not. As Dr. Erchinger mentioned, colon cancer doesn't need radiation, and for rectal cancer and anal cancer, radiation is a part of the therapy. Radiation is a scary word. Most people don't know what it means. They think about the Hulk or nuclear bombs, but this radiation treatment is more just high-dose X-rays. We shape it very carefully to try to minimize the side effects. It doesn't hurt, it doesn't burn, it doesn't make you radioactive, and it doesn't make you lose your hair. And patients with locally advanced rectal cancer, about a third to half of patients do not need surgery, and we can cure them with just the chemotherapy and the radiation. So that's all I have, and we can move on to questions.
Well, thank you, everybody. I am amazed with what information was shared by our experts here tonight. And the point that we wanted to make was to speak in your language, and hopefully we came across as talking in a way that is understanding and simple. That means you get screened, you can get cured. We've had a number of questions submitted to us during registration. We're going to answer them, and I would also like to offer you the opportunity to raise a question once we're finished with the pre-selected questions. I know sometimes people are uncomfortable trying to get a piece of information that's personal, and so we should be around after the program for a short period. If anybody wanted to come up and ask a personal question, that'd be fine as well. All right, so the first question submitted is, if there's no family history, when is a good age to start the screening? Does it differ from a man or a woman? And Dr. Penamutsa was going to answer that question.
Yes. So the guideline right now is 45 and above. Used to be 50, and now it's 45 and above. And you should consider talking to your primary care doctor about some sort of screening. Colonoscopy being the most ideal because you get the therapeutic effect and the diagnostic effect of it. As far as the difference between male and female, at the end of the day, it can be said that there's really no difference. If we're going to screen you 45 and above, I think bottom line is blanket screen for everyone. That being said, the mortality rate in men is slightly higher when it comes to colon cancer, and also the incidence or the lifetime risk of colon cancer in men is 1 in 23. In women, it's 1 in 25. So it's really not much of a difference. So at the end of the day, the take-home point is just get the colonoscopy.
Dr. Hanif, when will you do mutational testing, and is this performed at the time of diagnosis or if there's progression of the disease?
So there are a few types of mutation testing. One is to detect a gene that can be passed through families to generations. That kind of mutation testing is not done on everyone. It's done when our risk, we feel that the risk of having that gene is significant enough, such as a patient who's very young, or a patient who has a very strong family history, or a patient who unfortunately has multiple cancers. There's other kind of mutation testing that is done on the tumor to identify what's the best treatment options for them. And those kind of testing are usually done at the time of diagnosis. Now, as with the emergence of biomarker-directed therapies, sometimes we do additional mutation testing at the time of progression as well. So there are different mutation testings, and it could be done throughout the treatment, depending on when do we need to make a decision based on the results of those tests.
Thank you. Our third question is, what is the warning sign of this cancer that is often misdiagnosed as another disease? Dr. Aimee, will you answer that question for me?
So as we talked earlier, the most common presentation is rectal bleeding, and sometimes it's misdiagnosed as hemorrhoids, especially if the blood is mixed with stool. That's a big warning sign. Iron deficiency anemia that we can't explain, that's also another big one, as Amy's case. If you have any change of bowel habits, then you need to talk to your doctor about it. If you have any chronic bloating or chronic abdominal pain, then you need to discuss that with your doctor as well.
Thank you. The next question, how often should you be tested for colorectal cancer? Dr. Erchinger?
There are two ways to address this. One is how often for screening, and then potentially for surveillance. So screening is the general recommendation is it depends, and the other thing, it depends on what kind of screening test you're doing. As was discussed earlier, colonoscopy we think is kind of the gold standard, but it may not be for everyone. Colonoscopy routine screening for the average risk patient should be done every 10 years. And that means someone with no family history, no history of colon cancer, no history of polyps, and no risk factors or no signs and symptoms. So every 10 years for routine screening. For the Cologuard test, it's every 1 to 3 years, 3 years generally. For the people called blood test, it's every year. For the flexible sigmoidoscopy, every 5 years. For someone, an add-on to that, that's screening. So for someone who has polyps, the next question is how often do you need to do that? It depends on the size of the polyp, the number of polyps, and sometimes the histology of it. But for a typical tubular adenoma, the typical colon polyp, if you have fewer than 2 and they're less than 1 centimeter, 10 millimeters in size, you would do a repeat in about 5 years. 5 to 7 years is the general recommendation. If you have more than 3 of those, or more than 2 of those, or if they're larger size, then we recommend every 3 years. For patients who are at increased risk, family history, I generally recommend at least every 5 years. For someone who's had colon cancer and has viewed it, they're cured, we recommend another colonoscopy 1 year after their treatment. If that's completely normal, then we do 3 years, and then 5 years routinely after that. If you have an advanced polyp, then the frequency would increase. Polyp is at higher risk of becoming cancer, then the frequency would increase.
I hope you notice all of us are shaking our head in agreement, so there's no controversy here. We're all on the same page. The next is for Dr. Deivert, and the individual submitting this question understands that some health insurance companies won't pay for colonoscopies for patients over the age of 80. Do we as a panel agree with that? And the follow-up question is, who are they to say how long one should live? That's for a higher power to say. But what I will say is, do we agree with the fact that there should be a cutoff at age 80 as a blanket statement? And Dr. Deivert, why don't you?
I think, speaking for the panel, I guess I would say no. There is not necessarily a cutoff age. We did talk earlier about the colorectal cancer screening guidelines generally recommend screening from age 45 to up to 75, but that's not to say that patients over the age of 75 do not need screening. The guidelines do recommend kind of individualized screening beyond that. When I've done colonoscopies on patients certainly in their 80s. I think there was a mention about insurances. I've personally not ever really encountered anybody calling my office and saying, hey, you did this procedure and my insurance won't pay for it, or I'm getting a bill for this. So I've not personally encountered that. I'm sure you have. But definitely, certainly not up to the insurances necessarily when you should stop having colorectal cancer screening. If we knew how long everybody was going to live, we could definitely tell you when to stop having colon cancer screening. And I think, jokes aside, I think the general premise of that is that the biology of colon cancer, we think that, as I said earlier, finding and detecting polyps, removing polyps helps decrease the risk of colon cancer. So there's something that's described as the adenoma carcinoma sequence, or how long it takes a polyp to turn into cancer, which in somebody with normal biology generally takes about 10 years. So if a patient has had up-to-date colorectal cancer screening and they may not be appropriate for them to have colon cancer screening. It depends on a lot of factors: their overall health, their family history, meaning is there a history of longevity? Did their parents live to be 100 years old? Are they 85 years old and playing tennis every day and have no health problems? It really is an individualized decision, I think, between you and your provider based on your overall health, your risks, and I think also what you would want to be done. Because I think in the end, the question is, well, what if you were 85 years old and we did do a colonoscopy and found that you had colon cancer? Would you want surgery? Would you want to go through chemotherapy or something like that? So I think in general, no, we don't necessarily agree with that, and it should be an individualized decision.
Great answer. The final question is interesting the way it's worded, and I'll word it two ways. The question, this is going to be for Dr. Penwitza. When do you suggest Cologuard screening over a colonoscopy? But the question should be, when don't you do the Cologuard and have to do a colonoscopy? So this person is wanting, when do you suggest the one over the other? And I know the answer that you're going to say, and we'll
Well, let me paint it this way. If you were sitting in the office with me and I introduced the idea of a colonoscopy and I gave you all the information, I see the look on your face that you're not going to do it. Right? Then I turn into that sleazy car salesperson. I see the 1 foot out of the door, and I said, you know what? At the end of the day, that patient deserves to know that there is a second option. So I then kind of introduced the idea of the Cologuard. Now that being said, in the community, I'm sure the endoscopists on this panel will tell you, we get a lot of people Cologuard tests that get referred to us, and I think that's a good thing. I think if patients are leaning on the side of the Cologuard as a bounce off, it's better than none. I also understand that people, life catches up to you after a while. You're just busy, you've got a lot of kids, a lot of family things going on. So I know there's an element of that makes people lean on the side of saying, well, if I do a Cologuard, maybe I'll get away with it, Maybe I'll take that, maybe I'll roll that dice. But at the end of the day, I think all roads eventually lead to a colonoscopy. So when people get a Cologuard, it's really crucial for us to explain to them that if you're investing in doing a Cologuard test, you're technically already telling me that if it's positive, you're committing to come see me for a colonoscopy.
I think I just think he nailed the point I was hoping he would get to. Many people, as was outlined, who require a colonoscopy are going to have to take off a day of work. Probably the day of the preparation is going to be not the usual routine day. They're going to have a family member or friend who's going to have to take time to drive them, pick them up after the anesthesia. And many people don't have the time or the support system, for that matter, to be able to do that colonoscopy. And they'll say, well, I really want to do it, but I can't do it. I can't tolerate the prep. I don't have a friend to bring me. I'll do the Cologuard. But the stipulation is, and there's an agreement made between the physician and the patient, that is if the Cologuard is positive, you have to have a colonoscopy. And so the patient needs to know that up front, and then they say, well, I'm not going to have a colonoscopy, then you don't do the Cologuard, because you don't want a patient walking around with a positive Cologuard, which could be a false positive, thinking they have colon cancer, when in fact they don't. The other thing that's important is any individual that's had a polyp, a family history of colon cancer, or a previous cancer themselves can't do Cologuard, because you just can't do it, because there's abnormal cells in the stool, and they're going to show up as positive each time, and you're going to end up getting a colonoscopy each time. So for individuals who are at high risk or previous polyps, strong family history, you got to go with the colonoscopy. At this point in time, we're through the pre-registered questions. Does anybody from the audience have a question? And to whom would you like to address it?
Yes, that's one question.
Yes, sir.
Thanks for y'all's time, by the way. Great presentation, and thank you, Randy, for wanting to tell your story. I heard y'all talk about false positives with Cologuard. What about false negative? You ever get that? And I don't know who to ask that question to. I'm not smart enough to know.
False negatives, what we know about the Cologuard is that it does a good job detecting lesions, precancerous, some polyps that are in the early phases can get missed with the Cologuard, all right? Which is hence why we do it every 3 years. We're not confident enough for it to go beyond 3 years yet, as of right now. So that in itself tells you the value of what that test is bringing when you compare it with the colonoscopy. I hope I answered that.
Yeah.
Do you have a specificity rate? Can you?
So he did mention in his presentation that false, true positive versus false positive is what we refer to as the sensitivity. So if you take 100 patients with colon cancer and give them a Cologuard test, 8 of them are going to be negative. So 8 patients who have colon cancer are going to be walking around thinking, everything's fine because their Cologuard test was negative.
And again, to emphasize what was said, you don't stop there. You don't say, I had 1 negative Cologuard, I'm done. You're back in 3 years to do it again.
Exactly.
But in 3 years, who knows? In 3 years, you could have gone from curable disease to more advanced.
Any other questions? Yes, ma'am.
So if you had polyps and they were removed, eating a higher fiber diet, would that help prevent polyps from returning?
Who wants to take that one?
I don't think there's any data on that, but we do know that higher fiber diet, low red meat diet is healthier and tends to reduce your risk for colon cancer, which would indicate that reduced the incidence of polyp production as well. Certainly, I would not base a recommendation for surveillance on increasing fiber in my diet. So, if you have polyps, we do true polyp adenomas. We do recommend surveillance at the 3 or 5 to 7 year rate, depending on sizes.
Yes, ma'am.
Hi, so I just have a question around the environmental factors. I saw the statistics that were up there in regards to Luzerne County as far as the U.S., but I myself was diagnosed, I know Aimee was diagnosed. I had 2 friends all within Luzerne County and actually like right here from Myers, GA, that have passed away. And then I have about 3 friends now who are going through treatment. So it just seems strange to me, to your point, when you were saying 80% of the people that you met here had colon cancer. I'm just wondering if there's any speculation as to why that would be.
You know, that's a great question, and the statement that you just made is why we're all here today. When Mayor Brown and I talked and we heard about the statistics here, what we in Union decided was we don't know the answer. There's something happening, not only here but across the United States, and I don't know if it's what people are eating, what's in the plastic water bottles, what kids are doing, as was mentioned. Kids in the 90s have higher risk than the 50s. I'm sure people born in the 50s ate a lot more processed meat than the 90-year-old. You know, kids are eating yogurt and vegetables. So there's something out there. I don't know what it is. It could be something leaching from the river. It could be radon in the ground. I mean, that's all speculation. There's no one saying that that's what it is. But my experience in 24 hours with 80%, and your incredible experience with Aimee and other friends you know, it's horrible. It's just unbelievable that this is happening. But if you take away what was said tonight, it's a simple fix. It really is a simple fix. If people just move forward and say, I'm going to do this. March is Colorectal Cancer Awareness Month. That's why we're here. I think the majority of us are in blue. That's the color. I think some of the buildings in town are... some of the buildings in town.
Actually, a follow-up question.
Oh, yeah, please.
So if we're talking, and I do agree with you, it is a simple fix. You just get the colonoscopy, well, not just get it, but you get a colonoscopy and you determine if you have polyps, you get them removed. But if I'm correct in my understanding, it is a slow-growing cancer. So when I was diagnosed at 44. They told me that I probably got it about 34. So at that point, or it started at 34. So at that point, I wouldn't be able to get a colonoscopy. Would they do something?
No, I disagree with your statement, and I'll
Okay.
tell you why. When we talk about the average run-of-the-mill colon cancer, as was stated, the adenoma carcinoma paradigm, which starts with a small growth, small polyp gets bigger and bigger. By the time that starts to the time a polyp forms, it takes 10 years to become cancer. That's been the norm for people that are now 60, 70, 80 years of age. People like yourself have a completely different tumor. And what it is, it shifts to a different part of the colon, and it is very aggressive and develops rapidly. The majority of the cancers in individuals like yourself don't go from the adenoma polyp to a cancer. They bypass that polyp form. Most of these cancers are not polyp cancers. They grow right from the tissue in the colon, and it can happen over a matter of 3 years. So what we're saying is, first and foremost, as was mentioned by our internist, any change in symptoms, and I used to tell patients this all the time, most of the training you have when you're a young medical student is, oh, if someone gets new onset constipation, they've got a problem, check them. My experience over the years was more people presented with new onset diarrhea than they did constipation and had colon cancer. So I think the emphasis is anything changed, anything, you know, even as was mentioned earlier about having lifelong irritable bowel syndrome, something changed. And irritable bowel syndrome does overlap in some ways with people who have colon cancer, but irritable bowel doesn't start out of the blue in someone at age 30. And you go to a doctor and they say, oh, you're a 30-year-old woman, it's irritable bowel. And you say, you know, I've never had this, you know, this is new. That should be a red light. And you know, the other thing too is have a discussion with your doctor and say, I'm concerned, I've heard testimonies from people, I'd like to have a colonoscopy. And I don't know anybody on this panel who would say you don't need one. Anecdotal story, and this is a little graphic, but I saw this the other day. A nurse practitioner who worked in a maternal ward. She basically was a OBGYN nurse who probably acted as a midwife as well. She started noticing rectal bleeding. She went to her family doctor and she said, I have a problem, I'm having rectal bleeding. And he blew her off and he said, it's probably hemorrhoids. And she said, I'm a nurse, I know I don't have hemorrhoids. And he said, "You're probably having your period." And this woman looked at him and said, "Doctor, I see more vaginas in a day than you do in a month." I know I don't have, and she had advanced colon cancer. Now this is a smart woman who knows her body, knows the signs or symptoms, and the doctor's telling her, "Don't worry about it." That's why I think everybody here has to be their own advocate. If you say there's something wrong with me and your doctor blows you off, either ask for the test or go see another doctor. That's it.
Exactly.
Yes, ma'am, or sir, I'm sorry.
If you had colon cancer, right, how likely are you to get anal cancer?
Does anybody want to take that? I have an answer, but I'd like to share.
They're really not related. Anal cancer is similar to skin cancer, it's just that the anal, that's a different kind of a lining. So they're really not related. Even people who have anal cancers, it doesn't increase your need for colonoscopy. You are still considered an average risk for colon and rectal cancer. So they're really two different.
We could get into risk factors for that, but there are risk factors for anal cancer. It's a viral disease, and it's something that is treated completely different, but there's no correlation between the two. It's just connected to the same.
Okay.
Yes, sir.
As far as family history, I'm about to outlive my father by 10 years already. But I'd had polyps probably 20 plus years ago. My son recently had his colonoscopy done at 47. He hasn't lived in northeastern Pennsylvania in 20 some years. But they came up and said they had polyps, and he actually it's a sessile adenoma.
Yep.
And you want to know, is that something you should be very worried about?
He should be worried about it, but not necessarily very worried about it. When you think about polyps and the mushroom-shaped kind of polyp that was shown in the diagram is a classic adenomatous polyp. A sessile polyp means it's flatter, and so it's oftentimes more difficult to remove endoscopically, but it can be done. But sessile polyps tend to behave a little differently than the adenomatous because as they're flat, if they do develop a cancer, they're that much closer to the wall of the colon that it's going to spread quicker, not necessarily more aggressive, but quicker than the stalk that it has to go through, like the stalk of a mushroom before it gets to the wall. What I would say is the fact that you've had polyps. It doesn't matter how long someone outlived the other, but if you've had polyps, you should still be getting screened. You look like a young man. And then your son, who has a sessile polyp, that, as our surgical colleague mentioned, is going to move him up to maybe an every 3 year or maybe even every 1 year, depending on whether they remove the polyp. So if I were asked to remove a sessile polyp, and I go in and I remove it, so usually a polyp, as was mentioned, can be cut off and the whole thing is gone and you say, "I got the polyp, we're done." When you take a sessile polyp off, it's almost like scraping. You take the polyp snare, but you cut, and sometimes you have to cut it out in a piecemeal fashion, which means you take it out in little chunks. You have to come back in maybe 3 months to make sure that all of that tissue is gone. Then you may have them come back in a year to make sure that even though you didn't see something, something hasn't come back. So that's treated much more aggressively. Not that the tumor is more aggressive, but you are more aggressive. So I would recommend to your son that he get screened much more more often than the average.
In other words, to have a colonoscopy done in 3 months?
It depends on how they took it off. If they felt completely confident that they got it all, I would say a year. If the physician knew that he didn't get it all, or what happens is when you start cutting away at that, there may be some bleeding and then you lose sight of where the polyp is, and you're there's a point at which you say, "I'm done, I can't see what I'm doing." So you have to, kick it out a couple months and come back.
So my daughter and other son that are over 40 should get a colonoscopy done soon?
Absolutely, yeah. And how old is your son that has it?
47.
I would say they get it now, yeah, because it was mentioned that when there's family history and someone has at least colon cancer, you want to start screening 10 years before. In this case, with a sessile polyp, I would definitely have them screened at this point in time at 40. Agreed? Any thoughts on that? Any other questions? Oh, yes, ma'am.
My question is for Aimee. After all you've been through, from the very beginning, finding out of having cancer, making the decision to try chemo and radiation, to find out it wasn't successful, having to, to go through the whole surgery, you had to have emotional upset along with your family. Did you have any kind of psychological intervention, like help from therapists, or while you were in the hospital, or on your own, or was it suggested?
Yes, my doctors required it as part of my treatment. So they would check in with me every 3 months, and I would talk to them, and if I needed them, I was there, like had somebody to contact if I needed them. Luckily, I didn't need them that much, but I did have the resources there, and they did check on me periodically.
Thank you.
You're welcome.
Do you know if there's any association between gluten intolerance and a higher incidence of cancer? And second part, is there an association between celiac disease and GI cancers?
I'll take that one if you don't mind. Yeah, there is an increased risk of a lymphoma of the small bowel in celiac disease. It's a T-cell lymphoma, which is different than what are called B-cell lymphomas, which are the common. So individuals with celiac disease, an aggressive celiac disease that doesn't respond well to a gluten-free diet, should be aware of the fact that they are at risk for lymphoma. And if there's a sign or symptom change with their usual symptoms associated with that, they should alert their doctor, but a good gastroenterologist who's taking care of a person with gluten sensitivity should know, and I'm talking about celiac disease now, not gluten sensitivity, which a lot of people think they're gluten sensitive, and that is a very broad umbrella, but the bowel disease associated with gluten is celiac disease, and that is an inflammatory condition of the bowel that can lead to T-cell lymphoma. It's a very small risk, and there's no increased association with colon cancer with celiac disease, but there is small bowel. Another question? Yes, sir.
I just want to say there's some extraneous factors or powers to be that we're not discussing. I'll give you an example. I was supposed to have a colonoscopy in 5 years, and it's just over 5 years. I won't mention the hospital, but we called about 3 weeks ago, and we were told we're booked to July, and we're not making any appointments after that. I felt like saying, duh. And then they said, well, we'll put you on a callback list. Well, fortunately, the nice lady that took the call called me back later that day and made an appointment with, well, I have to go back. The doctor we had before is no longer there. So they just scheduled me with the new doctor. And it was scheduled for April 5th. Well, a week ago, they called and canceled that for no reason. So today we called again, and we were more or less told the same thing. They're going to call me back if and when they can find the time. So there's either not enough doctors, or maybe there should be a panel to decide.
I'm not in the community right now.
Someone else, or what?
I think our GI guys here might be able to better answer that. I don't know what the demand is in the valley. I'm personally not living here now, but can you guys comment on how far out you are for?
I mean, especially with the guidelines being dropped down to 45, we're definitely expecting there's a new surge of a lot of new patients that are going to be in that bracket. That being said, when you deal with any gastroenterology office, given the sheer volume that goes through their practice, sometimes it does appear that you're backlogged a little bit. I personally think 3 to 6 months is, beyond 6 months is definitely a stretch. I think reasonably you would see most practices backed up at least 2 months. I don't know if my peers agree with that or not, 2 to 3, you know. That being said, there might be some shortage in the community, like I said, maybe because of the surge. But, I think a lot of steps are being taken to recruit more gastroenterologists into the community. And I think that might have to do more with the market of, hiring, hospitals hiring. And obviously those are things that I can't really comment on. But like I said, I think at any point, if you feel like you're stretched out too far out, there's 2 things I need you to really keep in mind. One is to constantly stay engaged, which I think you have, and I think that's really good. You're very proactive, because some people might just let it go. They're looking for an excuse not to show up. So the second point I would say is, I think if you start noticing within that window any further changes in your bowel habits or any bleeding, then I think you really have a critical decision to make there. You might have to reach out to another community doctor for your own sake. So that would be my advice to give you from a patient perspective. But I understand that frustration. I think it's just not here. It's just probably everywhere. Like I said, the surge, the number of volume of patients out there, sometimes it takes a while to get there. But just remember those 2 things that I mentioned. Hopefully that'll help you.
Thanks. I had a couple of comments. I think definitely there is access issues or concerns in the community, and there's several factors that have contributed to that. One is change in screening guidelines. So we now have many more patients that need testing. Certainly the it seems like an eternity ago, but we are just beyond. I would say our practice has not necessarily caught up yet from the backlog of COVID, because when COVID started, we were not doing it. We didn't do procedures. Patients did not have colorectal cancer screening testing done, or colonoscopies at least. I think at Geisinger we encouraged a lot of people to utilize Cologuard as an alternative to colonoscopy, recognizing that a positive Cologuard would then triage them to get a sooner colonoscopy. But we still have not caught up with the backlog of provider turnover, the impact of COVID, and also the change in screening guidelines. I agree 100% with Dr. Penny-Metza that if there is any, if you're due for a surveillance exam or a follow-up exam because you had polyps and you're having any issues or concerns, certainly escalate that. And then another comment just is that in the past, the most recent surveillance guidelines that came out have changed. And I think that we are probably over surveying patients. For example, we've mentioned, I think several panelists have mentioned that, the previous guidelines were that if a patient had 1 or 2 small polyps, that they come back in 5 years. The most recent guidelines have changed that we recognize that patients who have small adenomas, meaning a benign, fairly benign precancerous polyps, their risk of developing colon cancer is very low, and that they probably do not need a follow-up colonoscopy for 7 to 10 years rather than 5 years. Some practices have gone to the extent of going back through their quote-unquote recall list and contacting patients and saying, hey, we know we told you to come back in 5 years, but you actually don't need to come back for 7 to 10 years. I know our practice is not doing that. Maybe not as well, but I know that there have been, I've read some recent literature discussing barriers to implementing such a strategy, but just a couple things to consider.
Good point. Any other questions? Yes, ma'am.
Yes, this is for the entire panel. I know some members of the population have what is called a tortuous colon, which makes it very difficult for colon prep to adequately clean out the colon for the procedure. Do you have any suggestions on how to better prep for a colonoscopy if you haven't had that kind of colon?
Comment on that. You raise a great point in that one of the most important parts that Dr. Kearney touched on, but we didn't really talk about very much, is that one of the absolute most important part, besides making the decision to get a colon cancer screening test, if you decide to have a colonoscopy, the absolute most important part is the prep. Without a thorough preparation or adequate preparation, it's impossible for us to find and remove polyps and help prevent you from developing colorectal cancer. The implications of that are that it may, if you don't have an adequate prep, it may change the recommendations as far as follow-up. You may need to reschedule. You may need to come back in 1 year or 2 years or 3 years instead of 5 years or 10 years. That being said, a lot of patients follow the recommended instructions to a T and still don't have a good prep. It's by no fault of their own. We know that there are factors that contribute to that. If they're on certain medications, if they have chronic constipation to start with. And generally what we'll do is if a patient has had and I would say that a tortuous colon doesn't necessarily increase your risk of having a poor preparation. It makes our job harder sometimes as colonoscopists to examine the colon or complete the examination, but it doesn't necessarily increase your risk, your likelihood of having a poor preparation. But there are things that we would do differently, perhaps a larger volume of preparation, 2-day bowel preparation, augmenting the preparation with some additional laxatives or other things to help improve the effectiveness of the bowel cleanse so that we can do a thorough enough examination.
I would like to emphasize that as well. It's crazy when you talk to patients and after a poor prep, you ask them what they did in the preparation. They said, oh, well, I took myself out to Olive Garden and got the big salad. And I knew I wasn't going to eat for the next day or two. So, and you get in there and you find the big salad. So I mean, what you have to do is be, cognizant of the fact that a low fiber diet, lots of liquids. If you know that you've had a poor prep, do 2 days, do the full prep that you have, and maybe your doctor would give you either a pro-motility agent to try and cleanse it at the end, or another laxative.
I'm going to add another comment just about preparation, because as I said, it's absolutely the most important part, is a lot of times we see patients who come in and we do a colonoscopy and they have a poor preparation, and afterwards you talk to them. And one of the things that is extremely important as far as the preparation is what's called a split dose bowel prep. And you might schedule a colonoscopy and you might get the instructions and they might tell you that you have to get up at 3 a.m. to drink half of your bowel prep. You absolutely have to do that. A lot of times when we see patients who have had a suboptimal preparation and we talk to them afterwards and they say, oh no, I drank it all last night. I wasn't getting up at 3 a.m. to finish it. It now makes the difference between, having a test done every 10 years versus, having to come back a year from now. So it's every 10 years if you have an excellent bowel prep when we do a very thorough examination. And the bowel prep is absolutely the most important part of that, and specifically the split dose bowel prep, doing half of it within 4 hours of the procedure is vitally important, particularly to clean out the right side of the colon or the proximal part of the colon, which is where we're seeing a lot more cancers develop in this.
Anything else? Are we, at this point in time, I'd like to ask Aimee, would you like to make any final remarks? Nothing?
I'm just thankful for everyone who's played a part in my journey and everything it does for me.
Oh, that's great. All right, well, as the moderator, I'm going to make my final remarks, and I can't not let the mayor wrap things up. But, we've had a lot of people here that we want to thank. It's been incredible from the onset, everybody that we asked to be involved, including the entire panel, jumped on this, and it was amazing. I'd like to personally thank my family who came to support. I'd like to thank King's College for giving me the education they did, and that's to you. And I'd also like to point out a gentleman in the audience, one of the preeminent internists from Wilkes-Barre, Pennsylvania, Dr. Vincent Drapiersky, who I would not be standing on this stage tonight if it wasn't for the influence of that man in my life. So I want to thank you, Vince.
Tom, thank you. And I want to thank everyone on the panel tonight. You gave up your time. I know it's your family time, it's your personal time. When we put this program together about a year ago, our goal was to hopefully save one life, to hopefully make sure someone gets the testing that these esteemed people are telling you should get. And I'm hoping that we achieve that. When I talked to Aimee and I said, Aimee, you're opening yourself up to the public about everything that you had done internally. And she said to me, Dad, if I could help one person that may not have to go through what I'm going through. That's what this is about, folks. Hopefully you took something away tonight. I know I learned a lot, and I'm just so happy with everyone that partnered with us, the colleges, the medical school, General Hospital, the media that helped us. And by the way, you might drive around the city and you might see different buildings. Wilkes-Barre City Hall lit up in royal blue. Wilkes College, Wilkes-Barre Hall, amazing job, lit up in blue. King's College, above the building, Christ the King is lit up in blue. That's all in recognition of colorectal cancer month, this month, and they are people that partner with us. So once again, I know you saved a life tonight. I know you helped people tonight, and I just can't say enough. Tom, thank you for coming in. I know it was a trip for you, but folks, hopefully you found something that was worthwhile to come out today. Thank you.